Hello and welcome to a very special online broadcast. Hopefully many people on Facebook and YouTube are joining us. We're being broadcast by the two charities, Made of Millions and Orchard OCD, a charity that I'm a trustee of and I feel very closely to. So I am Sean Fletcher. I'm a presenter. I present on television here in the UK. I know many of you are watching from around the world. There'll be people watching from the United States of America. It's probably quite early at parts of America at the moment. It's 4 o'clock here in the UK. Now, I'm not only a television presenter, I'm also a mental health campaigner with a particular interest in OCD. So my interest comes from my son who has OCD. He was diagnosed with OCD at the age of 13. He's now 17. But when he was diagnosed, I had no idea about mental illness and mental health. And within the space of a few weeks and months, my family, my wife and I sort of became experts, as many parents do when their children become ill with mental illness. So today we're going to be doing, I say it's a special broadcast because it is. We're going to be looking at OCD, existing and potential treatments for OCD. I've got an expert to talk to you about this in just a moment, but I want this to be really interactive. I want people to send their questions in. So if you're on Facebook, if you're on YouTube, you will be able to send some questions in. Actually, I noticed that someone called Shazam has sent something in and said, I'm first. It's not actually a question, but do send your questions in. I'm going to try and put them to our expert. Let me tell you who our expert is. It's Professor Naomi Fineberg. She, well, her title is a bit of a mouthful. We've just been talking off air, and I'm hoping I'm going to get this right. She's a professor in psychiatry at the University of Hertfordshire. She runs a highly specialised OCD service. So she's a consultant psychiatrist at the Hertfordshire Partnership University NHS Foundation Trust. It's a bit of a mouthful. All you need to know is she's one of the leading experts in OCD research in the UK. So let's see if we can bring her in now. Naomi, good to see you. Did I get all that right?
You certainly did, Sean. Thank you.
Because literally 2 minutes before we came on air, I told you what I was going to say, and you said, no, that's all wrong. We're going to have to change all of that. So I had to reword all of that. I literally wrote it down at the top of my screen. But as long as I got it right, and as I say to people who are listening, the key thing is they need to know that you are an expert in all things OCD. We did, just to people who are watching, we did a little chat. We had a little chat a few days ago on Zoom. And I have loads of questions and loads of interest in OCD. I know just through experience about OCD through my son, I asked Naomi, I threw loads of questions at her and she answered every single one perfectly. So we've got an hour now to talk to her, and I can see questions already coming in, but I'm going to start with the first question. So Naomi, just bear in mind that we've got people from all over the world listening in. We've got people who know very little about OCD. They're new to it. They may be parents, like I was a few years ago, who are just discovering their child has OCD, has been diagnosed with OCD. And there'll be other people who know lots about OCD. So I suppose in the way we pitch this, we need to be bearing that in mind. And just to start with then, can you explain what's the first line of treatment when someone is diagnosed with OCD?
So I think the first thing to do is go to see the GP. That's the best thing to do if you're in the UK, or the primary care doctor if you're abroad in other countries, because the first line treatment could either be with a psychological form of treatment, which is called cognitive behavior therapy. And that I can explain in a little bit more detail, but essentially involves learning how to resist the compulsive rituals and deal with the anxiety that entails. So it's quite a difficult form of treatment, but it's very effective. And the other form of first-line treatment is with medication. And that's with what's called a selective serotonin reuptake inhibitor, SSRI, which were first marketed as antidepressants and then as anti-anxiety treatments. And because OCD is often lags behind these other disorders, ultimately are now licensed for treating OCD as well. And they're also very effective. And so that's why I say it's good to go to a doctor, the primary care doctor, to discuss these options, because the doctor can help you decide which of those two might be suitable for you, and then organise for you to get the right care through either psychological services or through prescribing the medication him or herself. This is
do those two go together? Sorry, Naomi, do those two go together?
Yeah, you could have both, but the guidelines at the moment are not clear about whether you need to have both at the same time. my empirical advice, so this is based on opinion, is that if your symptoms are more than just moderately problematic, there's probably good sense in trying both together, and they'd certainly complement one another. It's just, of course, two treatments are more costly and burdensome than one. So if the symptoms are relatively mild, you might prefer to start with just one of those two alternatives.
So explain what CBT is, cognitive behavioral therapy. From my sort of basic understanding, I'm watching my son go through it. It's sort of, you're almost retraining the brain to respond to things that might trigger you in a different way. Is that fair to say?
I think that's exactly right. You are retraining the brain. So that tells you straight away that it's an effortful treatment. It's not a reflective treatment where you just think about things. It's a training manual, in a sense, where we get the individual to work out what the compulsive behaviors are, what's triggering them. And then rather than encouraging them to avoid these triggers, we actually expose the individual to the triggers, which brings on the urge to do the compulsive behavior. And we encourage them not to do the compulsive behavior, and therefore disconnect the urge from the action and learn to hold on to the thought that they have to do something without having to do it, because nothing terrible is going to happen. And this, as you can imagine, it's very easy to talk about, makes a great deal of sense when you talk about it, but people have often been struggling for years to do just that. So it's not as easy as it sounds, and it requires a lot of practice. And we start with very easy challenges. So if it's somebody, for example, who's worrying about contamination, and they don't like to touch bins or blood or things like that, we wouldn't start with the most difficult things, but we'd start with the easiest things, like maybe touching a door handle that usually isn't too problematic, but might induce an urge to go and wash. And then the treatment would be all about generating that mild urge to wash and restraining it, not doing it, and reframing it in your mind as not being a dangerous act not to wash, and then practicing it. Usually we say 3 times a day, practice, 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 rather like practicing a musical instrument or training for a marathon. And then, of course, it's not like people say, oh, well, is it like riding a bike? It isn't like riding a bike, because riding a bike gets easier. Behavior therapy kind of gets more difficult. It's like pushing a boulder up a mountain, because then we say, okay, you've achieved that, right? We increase the ante a bit. We then say, well, let's do something a little bit more difficult. Now you've learned the technique, and eventually through an agreed hierarchy, agreed list of gradually increasing goals, we gradually move up so that the individual is getting confidence and managing to resist even the most difficult compulsions. And in so doing, they learn to let go of the thoughts. So it's a very behavioral form of treatment. It's not just thinking about, whether I need to do it. It's actually practicing not doing the compulsions and realizing that they're redundant.
And then that would go hand in hand with the drug, the medication that you talked about, the SSRIs. Would they make it easier to expose yourself to the very things that you fear?
Exactly how, precisely how the medication and the therapy works is not entirely clear. But we think that the medication, we know it reduces anxiety. So it takes the sting, the distress out of the situation. So it allows people to think more clearly. We also think that by reducing anxiety, it stops people behaving in an automatic, habitual way. So it allows people to actually take 5, think clearly, do I really need to do this? And realize they don't need to. So we think it works in probably in 2 different ways. Just in one hand, improving mood and anxiety, but in the other hand, helping people think more clearly about what their priorities are, whether they really need to do this or not. And so you can see how together there's congruence. They actually work hand in hand. And in my experience, people are much more successful at their CBT, as I said, particularly if their OCD is quite bad, if they're having some medication as well.
Okay, we've got lots of comments coming in. Quite a few of them. I noticed. So Elizabeth Gonzalez and Alex Anderson. I think a few of you have talked about what happens if the SSRIs and the CBT doesn't work. We are going to be getting onto that in just a moment, but just to clear up a few of the messages coming in, well, just to display that we are talking to people around the world. Vanessa Duval, great to listen to you from Montreal, Canada. And then she goes on to say, how does ERP work for Puro or mental compulsions only? So ERP is, can you explain what that is? And then explain what Puro is, and sort of try and make head to tail of that question and get an answer.
Yeah, well, mental compulsions, I think you've put your finger on it, listener from Canada. Mental compulsions are compulsions. So behaviors are not just physical behaviors, they are mental behaviors as well. And so a lot of mental compulsions, Puro is talking about pure obsessions, but usually a lot of that obsessional thinking, if you drill down into it, involves a lot of mental compulsion. In other words, mentally checking, what did I touch? Where did I go? How did they look at me? Did they think I looked dangerous or not? So there's a lot of what's actually checking going on, or reassurance seeking going on in the mental analysis. And so the ERP, which is the exposure response prevention, exposes you to the trigger that brings on the mental analysis. So whatever it is, and you'd identify with your therapist those situations that would trigger that thinking being the compulsion. And then we would ask you to allow the thoughts to come and go in your head, but not engage in the mental analysis. Now, on the one hand, that sounds quite straightforward. On the other hand, you can imagine it's not that easy to disconnect from mental urges to remind yourself or reframe what you did or recollect or think through. But if you can envisage it more like flicking through a photo album of all the things you've touched and seen, that technique can sometimes help you to just let go and not engage in the mental analysis that is mental compulsions. So rather than avoiding, facing up to the urge and then not engaging.
Yeah, it gets so complicated, doesn't it? How important is it to catch OCD, to diagnose OCD and start treating it early? And does that affect then the long-term treatment, that actually you don't need treatment for as long because you've got it early? And I say that sort of selfishly. I say that selfishly because my son, he was diagnosed when he was 13. And I mean, it was awful. It ripped our family apart. There was a terrible time. But I remember someone actually quite well known in the UK, the Telegraph journalist who has OCD, and we've had on this this webinar before, Bryony Gordon. She took me inside and said, but you're the lucky one because you've diagnosed your son with OCD early and you're treating him early and you'll benefit from that. And of course, that's the last thing you think when you're going through hell and your son is really struggling with OCD. But I realize now that was very good that we got it early. Yeah, how important is that?
So this is such an important and complex issue because no parent wants their son or daughter to have a diagnosis of a mental illness. We completely understand that, unless it really matters and it's going to really be helpful. And we have to accept that there's a lot of stigma around mental illness. So I don't think we can ignore that. But on the other hand, there is now really quite substantial evidence to suggest that the longer you leave OCD, the harder it is to treat. And the longer it takes to get well, and the more intensive it has to be treated. So that does argue quite strongly for intervening early. Now, in the UK, we do have services for other mental disorders called early intervention services. We have for psychosis, for example. So the idea is not new in psychiatry, but it's not something that's usually applied in the field of OCD. So Sean, as you said, I mean, your son is lucky. The majority of people I see have been ill for between 8, 10, 15 years before they've
That's tragic. I mean, that is tragic, Naomi, that you could go on suffering for so long without actually dealing with it.
Yeah. So I think the key is if you're a parent and you see your child and they're struggling, I think that would be a way. If they're struggling, if they are distressed, then do seek some help for them. And that might be, if this is very early stages, it's not necessary they need to go on medication. They may have some psychological treatment. It may be, one of the interesting things about OCD is it's an illness that really strongly runs in families. So there may be things that you as a family could do if you're reinforcing some of this obsessive compulsive behavior yourself. If you notice in yourself that you're a little bit obsessional, you might want to just adapt your behavior, simple things you could do to not reinforce obsessive compulsive behaviors in the child. Don't make them take their shoes off unless there's a religious reason to do so. Don't make them take their shoes off before they come into the house if you've noticed they've got contamination related rituals, that sort of thing. So there's various things that parents can do, but if the child is struggling, I would strongly recommend that you seek some medical guidance as to whether treatment might be helpful.
What should you look out for? I know that we're meant to be talking about existing and future treatments for OCD, but just there'll be people watching this, parents probably, or even people who are struggling themselves, and they'll think, oh, that sounds like my child, or that sounds like me. Just very briefly, what should you be looking out for? What are the alarm? What's the red flag for OCD?
Well, the evidence suggests that some of the earliest symptoms to come on are ordering and arranging and symmetry obsessions. So if you've got a child who's lining absolutely everything up or needing things to be symmetrical in young life, so we're talking about the age of 5, 6, something like that, then that might be a hint that OCD is starting. The other thing to say is if you've got OCD yourself, or and there's something called, I don't want to use technical jargon, but assortative mating, which sounds very technical, but actually it means that somewhat obsessional men and somewhat obsessional women tend to get together and have children together, and then their children may be more at risk. So if you are obsessional yourself, even if you haven't got diagnosed OCD and or your partner is, then just be aware that if you see these early signs of children, or the rituals where they're starting asking for a lot of reassurance, before you leave the room, you've got to do things a certain number of times. They have bedtime rituals. And if they become distressing, if there's something that they just can't stop doing, they get very distressed if you as a parent won't accommodate these rituals, then I think it would be worth seeking some medical advice just to check out with an objective health physician that in case this is an illness.
Okay, I want to get on to the potential new treatments, but I just want to go through a few of the messages that are coming in. Alex Anderson has said, thanks for the stream. Didn't think you guys were watching the chat. So yeah, we're watching what you say. So let's go to one of your comments then, Alex. My worst OCDs are fear of 13, which are reinforced by culture and philosophical, existential OCD, if I can read the comment correctly. I don't know if that's a question and that's something you want to answer. I'll just go on to another one. So I want to break free has said, what should we do if we don't have specialists who does ERP, so exposure response prevention, in our area? Is this something that you can do at home yourself, or do you need specialist help?
So there are online versions of the treatment that you can access. They're not as tried and tested, let's put it that way, as face-to-face ERP. So it's very hard for me in the current state of science to recommend them, but the principles are roughly the same, and you should be able to access them via, as I say, via the GP, via psychological services. But there are many parts of the world where, access is difficult. The medication is another alternative to really think about seriously. I say that advisedly because under COVID, it's actually not that easy to deliver or receive ERP, because a lot of the aspects of ERP we normally encourage, we just can't do. So we've had to really adapt the ERP, and it may even be ERP light for people with contamination fears. So I wouldn't ignore medication as being an equivalent treatment if you're having difficulty getting the real ERP. But you may be able to access various online websites where it could be available. There was one in the UK called BT Steps that was available for a while and may still be.
B as in for beta and T for Teddy.
BT behavior therapy steps was one of them.
Okay, so that's worth looking out for. Just a couple more before we go on. Jason Heike has said, what do you do when the obsession itself is a fear of having OCD and the patient refuses treatment? I mean, I sort of have personal experience of that in our family, and the OCD, it becomes so complex that it's like a shapeshifter, and it changes itself so cleverly that it's actually very difficult to tackle. What would you do in that situation?
Well, the key is to develop what you would call a therapeutic alliance, is to find ways of communicating with the individual and reach some kind of compromise arrangement whereby they're able to seek treatment. And most psychiatrists are very familiar with the problem of a patient whose insight is maybe not that great. And so we have ways and means of working with families to build a trusting relationship, to allow the individual then to accept that there might be something wrong and bring them into treatment without being too dramatic about the whole thing. So I think, providing them with education, providing them with books on the subject, introducing them to consumer support groups, just to show that there are other people like them. These are the sort of common sense things that families or carers can do to gradually allow the individual to let go of their anxiety and realize that this is something that can be treated. Because even with these existential forms of OCD, they're actually really quite common. People think they're alone, and then they see somebody else on a consumer website and they think, oh gosh, actually, my relatives are talking sense. This is OCD.
Yeah. Actually, it's really interesting you say that, because one of the best things we did when my son was treated at the Maudsley Hospital in South London, and one of the best things we did was a sort of family therapy where we got together with other families. And I remember my son sort of locked a bit in his OCD, and then he saw other people and thought, well, that's ridiculous. What their OCD is ridiculous. And I think it gave him a perspective on his own that actually, I realized that maybe the thoughts that I'm having and the compulsions that I do actually are ridiculous itself. But it took him to see a similar thing in someone else for him to see that it didn't actually work in himself. So just to move this on then. So we know that CBT and SSRIs are sort of the first port of call. We've got a question in here from Go Fast Clad 97. No meds or ERP has helped me. What are the future treatments for OCD? And can you explain, so CBT and SSRIs, what sort of percentage of people do they work for? And then how would you answer Go Fast Clad 97's comments that actually, the ERP doesn't work? What do they do?
Yeah. So my service is designed for people just like you, Go Fast, who've had the standard treatment at home and it hasn't worked, and they're wanting, something a bit more intensive or a bit different. So the first thing to do is to absolutely rigorously check that they've had the right treatment. And I'm not discounting the fact, I'm not disputing that you, Go Fast, haven't. But it is very often the case that people think they've had CBT for OCD and they really haven't. So the first thing that any card-carrying OCD specialist would do is really look very deeply. And so don't get offended, please, anybody who goes to see someone like me who starts really asking very detailed questions about your therapy, what it involved, how many sessions you had, how assiduously you did the homework. We're not being critical. We just need to establish that you really are not responding to the right kind of treatment, so we don't repeat it again. Similarly, with the medication, you need to be on the highest dose, usually. That's the highest dose within the licensed range for the treatment to work. There's something about the highest dose, and just as an aside, OCD used to be thought of as an anxiety disorder. It isn't anymore. It's in its own class of mental disorders, alongside other compulsive disorders, and it needs higher doses of medication than does depression or anxiety. So the treatment is different. So we would make sure, and we would ask you, how long did you have it for, at what dose? So please don't get fed up with us. We're just checking that you really have had the right treatment for OCD. And then with the CBT, we would make sure you'd had a home-based, if a clinic-based treatment didn't work, we'd do a home-based treatment. And with the SSRI, if one treatment didn't work, we'd try a second one, because not everybody responds to everyone the same way. Now, assuming that you have had the right kind of treatment, both psychological or CBT, and we might then recommend you have the two together to see if they work. Once you've had those, I would say up to 70% of people will respond to those treatments. It won't be a perfect response. It's very rarely a complete cure, but the symptoms go into abeyance and they're not troublesome anymore. And people are very happy. About 70% of people are very happy with the response they make. So that's quite typical of psychiatry. But that leaves a lot of people, about a 30% plus of people, for whom that isn't the case, or they relapse. And the one thing I should say is that for medication, it only seems to work if you take it. And if you stop it, there's a very strong chance that you will relapse. So if you're lucky and you've responded, a message would be stay on it. Because if you stop it, there's a strong chance you relapse. And the trouble is we can't tell who will. So we just, at the moment, our research is at a primitive level. So we can't tell who can safely stop it. So if you're doing well on it, stay on it. But
that's interesting. I didn't know that, because sorry, I'm always being selfish here, because with my son, he's on fluoxetine, and we thought of the summer during lockdown while he's at home would be an opportunity to reduce the medication, but that's not necessarily a good idea.
I wouldn't recommend it. And the other thing to say, people think, oh, well, I'm doing well now, I could cut the dose down, I don't need to be on the maximum dose. And that's a bit of a fallacy. We say the dose that gets you well keeps you well, because actually it's easier to get well. It's hard to stay well. When you're getting well, there's a lot of factors in your favor. People are being nice to you. You're seeing doctors. You're having therapy. People are paying attention to your problems and making allowances for you. As soon as you're well, all of that goes out the window. They just expect you to cope like everybody else. And life sucks at times. Life happens. Your pet dies, things go wrong, work is difficult, COVID happens. So staying well with OCD is really difficult, because we think the brain processes aren't cured by the medication. They're just reversed, and there's a stickiness about OCD. It's a bit like an elastic band. You can stretch it, but as soon as you let go, it sort of snaps back to how it was. So be cautious about stopping medication. But let's assume you've had the right medication, you've had the CBT, and you're still not well. What options are there? Well, the strongest evidence-based option is to add in a very low dose of an antipsychotic medication. And that seems to work. It acts on a different chemical system. The selective serotonin reuptake inhibitors, unsurprisingly, work on serotonin, which is a brain hormone, if you like, that promotes resilience and allows you to manage anxiety without getting overwhelmed by it, and manage depression as well, and helps you bias your thoughts towards the more positive, so you become more can-do, more positive in life. The antipsychotics act on another chemical. They shouldn't really be called antipsychotics because we're not using them for psychosis. They're used now as mood stabilizers and antidepressants. They act on a different chemical called dopamine. The dopamine is the chemical that tells you that something is salient, something is relevant for you. You've got to do something. So it's like an alarm bell in your head. Oh my goodness, you've got to act. So you could see how a drug like a dopamine blocker that just actually subdues that a bit and says, hang on a minute, don't overreact, just wait a minute and think this through before doing your compulsion, could really be quite helpful. So does it make you
dozy or slower in any way?
Not usually. In the tiny doses that we use for OCD, it's usually well tolerated. But I have to say it's not as well tolerated as SSRIs. And the main problem, The main problem for women is a little bit of weight gain on some of these drugs. So we would try to actually tailor the drug to the person. Weight gain is probably the main issue for most people using antipsychotics. But in the dose we use them, they're usually well tolerated, but not as well tolerated as SSRIs. So that in a nutshell is the evidence-based treatment for OCD. The stuff that's evidence-based means that it's been tried out in scientific trials against a placebo or a neutral treatment and found to be effective. And card-carrying doctors and nurses and psychologists would be more than happy to deliver it to you. Once we move away from that, then we are in territory that's relatively experimental. And so you can see that there's not a lot to offer people. If you've not responded to these treatments, there isn't really a lot to offer people. Now, there are a variety of different techniques that are under research at the moment, and some of them seem to be very promising, but I just want to preface all my remarks about them by emphasizing the fact that most of these are considered experimental. So it's to give you some hope that there are new treatments on the horizon, but not to necessarily expect you to be able to access these treatments at home unless you're in a specialist service or close to someone who's very interested in researching OCD. So I'm not sure, Sean, if there are any particular of these experimental treatments you want me to talk about.
Yeah, well, I mean, so you've obviously got a few up your sleeve. Let me just bring up Alex Anderson's comment. Can I ask the doctor her opinions on the up-and-coming studies showing psychedelic and MDMA therapy help with PTSD and other issues? They were used in therapy before outlawed. Could they get at the OCD? I'm not sure where you go on with that. Oh, I see. He does go on, get at the root of OCD and depression. And he goes on about doctor supervision, of course. Do you get the gist of that question?
I do. So that is one very interesting area. So, I mean, the good news for people with OCD, it's a bit of a paradox, really. It's a mental disorder about which we probably know much more than many other mental disorders in terms of the brain chemistry and in terms of the brain anatomy and the processing issues that seem to go a bit awry when you've got OCD. But on the other hand, there's been very little investment in the research of OCD. So in clinical terms, so that's where, the audience here, the more impact you can make on decision makers to improve the clinical research in OCD, the easier it will be for us clinicians to get you the right treatments. One area that we're now looking at is the use of hallucinogenic drugs such as psilocybin in OCD. It's a very, very preliminary investigation, and we're not particularly interested in this drug because it causes hallucinations or out-of-body derealization experiences, or its kind of spiritual effects. That's not our main area of interest. We're interested because this particular drug, psilocybin, acts on the chemical called serotonin, the one that's in the SSRIs. It's the same chemical. It acts, if you like, it mimics serotonin in the brain. And in various other experiments in animals, it seems to be that action of psilocybin may be very relevant for the treatment effect of SSRIs. And so if SSRIs work in OCD, there's a strong suggestion that psilocybin might as well, because it's pushing on the same buttons. And if anything, it might be pushing harder on the same buttons. So there was one study quite a few years ago in America, which was a very preliminary study that looked at just a few people with OCD and gave them various doses of psilocybin and just looked to see whether it was helpful or not. Of course, this was a selected group of individuals, because if you were to speak to most people with OCD, they'd be probably quite anxious about the idea of having a psychedelic experience, and probably the last thing they'd want to do. But for this group of individuals who took it, a proportion of them felt a lot better. And they didn't just feel better that day, their benefit lasted. Even though they only had one dose, the benefit lasted for quite a few days. So we are about to actually start a study. It's interesting, and I think Sean probably knows that we're about to start a study in the UK looking at psilocybin. We're not, because this is very new to us, we're not sure how people with OCD are going to react to the whole idea of taking this. And of course, all the complications, because it's a drug that's controlled, it's a Schedule 1 drug, it's not known to have medical benefits at the moment until these are proven. So it's difficult to access, but we have accessed it through our links with Professor David Nutt at Imperial College. So we're going to look to see, we again just going to give a challenge dose to people with OCD, A, to see how they feel about having it, and B, to see whether a very small dose that still acts on the serotonin, whether it gives a signal of any benefit at all in terms of a mild relief of OCD or some improvement in some of the information processing tasks that we know are a sort of a model, a proxy model for OCD. So if people look like they're thinking more clearly under the psilocybin, that would allow us then to ask for funding for a proper clinical trial. I think there may be other trials afoot in the United States as well. If you look online, you might see that other trials looking at psilocybin are registered. So my guess is in the next 2 or 3 years, we should have an answer to the question, is psilocybin, which seems to be helpful for some people with depression, is it also likely to be helpful for people with OCD? And I think that would, be a very different approach to the disorder and maybe helpful for a group of individuals.
Yeah, just to get to the messages. So Cynthia Garza, so this is on an earlier point. I stopped taking my medication, relapse. So I 100% agree. We've got Music, Raider 21, the charity Orchard OCD, which we just mentioned and which we are both involved with, works specifically to raise funds for OCD treatments too. So just going back to that, so the work that Orchard are doing, using psilocybin, the idea would be that you wouldn't be on any other medication and you wouldn't be having CBT, and you would have psilocybin, or does it go hand in hand with CBT in the same way that SSRIs would go hand in hand?
So if psilocybin is really important question, if psilocybin is pushing on the same button as an SSRI, would you have the two of them? The question is, we just don't know the answer to that. Would it complement CBT? Should be no reason why you shouldn't do the two together. So actually positioning it as an add-on treatment or as a treatment on its own, we are not yet there. These are questions we just can't answer. What we're a little bit concerned about is that if people are on too much medication and we're only giving them this small dose of psilocybin, we may camouflage any effect of psilocybin. So what we're saying to patients is, no way do we want them to stop their medication if it's really helping them. But if they're not on too much medication, we will allow them to stay on that, and we won't be giving them CBT during the course of the challenge, which is just going to be a couple of weeks or so. So, those would be our stipulations.
So it's a microdose, or it's not a microdose, is it? But it's a very small amount. So it's not like you will be, because this is the active ingredient in magic mushrooms. It's not like you will be having an experience that you would if you were having magic mushrooms, but it's not quite a microdose, is it?
So it's not a microdose, it's 10 milligrams. And you might get a small minor depersonalization experience. So I can't promise that you won't feel anything, but that's not what we're aiming at. We're not aiming at a spiritual experience or derealization or hallucinations. We really just want to see we're interested in the pharmacological effect of this agent on the nerves in your brain to see if it'll turn off the OCD.
So go fast, glad that we've had you on before. OCD is the most debilitating mental illness to live with, and that's where when I saw OCD at its worst in my son, I could see that it was just as debilitating as a physical disability, because someone who can't feed themselves, can't brush their teeth, can't get out of bed, is unable to do anything. And so that's what made me feel passionate about getting involved. Not just, I keep saying selfishly, of course there is an element of that because of my son, but it made me realize that not much is being done not much is being spent on finding new treatments. Talk to us about other things. We've talked about psilocybin, we've talked about the first line. What other things are there?
Can I just develop that theme for one moment before we go into more esoteric things, because this is something that I think could be is very close to my heart. The functional disability associated with OCD. The World Health Organization has recognized it as being in the top 10 most disabling illnesses. And so, in fact, I was remiss in saying that there's a third arm of treatment. So it's not just psychological treatment, it's not just medication. There is a third arm of treatment, but that arm of treatment hasn't been very well evidence-based, and that's occupational therapy and social support and helping people manage their functional disability. So I think occupation, we have a profession in the UK, it's not worldwide, called occupational therapists, who are very expert in understanding people's disabilities and what gets in the way of them getting on with their lives. And I think an occupational therapy assessment and help in managing prompting and pacing, people get stuck, people get involved in avoidance, helping them find practical strategies to manage their everyday life, having a strict getting up in the morning time, going to bed time, because we know that the rituals delay going to bed, have people who are completely nocturnal with OCD because it's quieter there, they think that they can get on with their rituals better. There are all sorts of reasons, but anyway, getting behavioral activation, having a timetable, things to distract you so you're not just sitting on your own with your obsessional thoughts. This is an essential ingredient of care for severe OCD, and it's often neglected by community mental health teams who don't see a role for themselves. It's often what I'm told, I can't see a role. So the role is to really understand the person's disability and help them function with these very generic activities, nothing specialist about them, because people with OCD need it.
But would that be avoidance, Naomi? Would that be avoidance?
Not necessarily. It's helping them find strategies for getting out the house and getting there. I have people who spend all day online, let's say, and the occupational therapist works with them to turn off the computer, get out of the house and do some gardening. Yeah, that's the sort of thing. And having someone on your side reminding you to do that, because when you're stuck in your OCD on your own, it just kind of goes out. There's always another priority that's more important. So occupational therapists are really great at doing that. So I strongly recommend them. Anyway, as it were, from the sublime to the ridiculous, let's talk about some other strategies we could think about. As I've said, we're understanding very much more about the brain circuitry involved in OCD. And so the various ways in which we can turn on and turn off this brain circuitry. And this started with very primitive brain experiments, which in the distant history of psychiatry were, really considered bad practice, the leucotomies, but which have been refined over the years into very specific surgical techniques where people with most severe OCD, kind of people who are completely hospitalized because they're doubly incontinent, can't get to the toilet, can't speak, can't do anything with OCD, they may opt for still a surgical approach which disconnects that one of those overactive circuits in the brain that we've pinpointed in a very specific way and is effective for this very, very severe OCD in the majority of cases. And these are people, of course, who've tried absolutely everything and nothing has worked. Now, of course, most people aren't that keen on the idea of having brain surgery where a little bit of brain is removed. So we've moved on a little bit from that to look at other techniques. I have to say that that brain surgery, the ablative brain surgery, is still probably the most effective treatment for this very, very extreme severe OCD. But newer alternatives involve stimulating these circuits rather than lesioning them with ultrasound or with a surgical instrument. And there are a number of models, and people who are familiar with Parkinson's disease or Tourette syndrome may be familiar with the idea of implanting electrodes in the brain. It's now quite common to help the tremor of Parkinson's disease. And in fact, in OCD now, there's experimental work showing that implanting electrodes in the brain and stimulating roughly the same areas that the surgical techniques disconnect, turn them off, probably, we're not entirely sure, but probably turn them off in a similar way that's more palatable to patients in as much as it's thought to be more reversible. It has its own side effects, and it involves, being under regular review by neuropsychiatrists and psychiatrists. But that's also extremely effective in more than half of the cases who've otherwise, all treatment has failed. But of course, you can't give everybody with OCD electrodes implanted. They wouldn't want it, or they may not be so severe. So there are other newer ways of stimulating the same intracerebral brain circuitry that don't involve a surgical operation. And the commonest way of doing that is with magnets, and that's called repetitive transcranial magnetic stimulation. And that involves putting a big magnet over your head and targeting it at the same circuitry that we think is misfiring in OCD. And that subtly either turns off, or in other areas that we think are needed to counterbalance the OCD, might turn that on. And that technique of transcranial magnetic stimulation, again, experiments suggest that can be quite helpful, and it can be used as an add-on to the CBT and the SSRI. And so that's something that's becoming much more popular. It's not licensed or approved in the UK at the moment. NICE guidelines looked at it recently and didn't approve it, but the evidence is definitely accruing. And I think in the States, the FDA may have given permission for use of one of these coils to be used for OCD. So that's something that's, watch this space. This is, a technique that's going to be going somewhere, I think.
Transcranial magnetic stimulation, you call it TMS.
TMS.
Okay, yeah. And that would be used while you are doing your ERP to help you be able to achieve greater things.
For your ERP, that's it. You could have a little stimulation. You could be even practicing. If you're the lady or the man with the Pure O, with the mental analysis, you might try and bring on the urge to ritualize, to do your mental analysis whilst you're actually having the magnetic stimulation, and try and resist whilst you're doing that. But of course, the thing with a big magnet is it's quite a cumbersome thing. It's expensive. It needs technicians. So we're not suggesting that people buy this big magnet. You have to go to a unit for it. And, we really want treatments that people can be practical and feasible for people to use in their lives. So we're moving on to something called direct current stimulation. So this is called transcranial direct current stimulation, which involves a couple of tiny little electrodes. It's one applied to the brain and one applied usually to the shoulder blade. And it gives you a microdose of electricity. It's 2 milliamps. It's like I was saying to Sean before, it's a bit like a TENS machine that those of us who've had babies might have been offered in the delivery suite. You feel a tiny little buzz, but it gets through the scalp into the cortex of the brain underneath. It probably doesn't go deep into the brain, so it's not having the same effect as the deep brain stimulation, which gets right into the deeper parts of the brain that we think are involved in OCD. But there are more superficial parts of the brain that are important as well, and it does seem to target those areas. And so there are now studies afoot. It was, again, first researched in depression, because we're always lagging behind depression. Quite a bit of evidence to suggest that it can be a helpful add-on treatment for people with depression. And so we're now looking at OCD, and we in my unit and other people elsewhere in the world are looking at direct current stimulation as a more user-friendly alternative to TMS. And then if we can show that does work, that's something that people might be able to apply, exactly as you say, Sean, in their own homes whilst they're doing their ERP. They could have this on their head. It's like a little swimming cap that you put on your head, and the electrode is there and the other one's on your shoulder. It's very easy to use. It'd be very easy for people to apply themselves.
So what's that called again? Transcranial, can you say that?
Transcranial direct current stimulation.
Okay.
TDCS, direct current stimulation. So, we're trying to marry sort of very sophisticated neuroscience with treatments that people can just apply themselves in their own home, and not get, too worried about it.
And how, I mean, the people listening who are really struggling with OCD might think, oh, great, I want to try that. These are not things that you can really do and openly buy on the market.
We don't really know the rights. I know it sounds silly, but it's the sweet spot. Where is the best place to put it? I just can't tell you yet, but be reassured that there's quite a lot of work going on to work these things out. So I would say within the next 2 or 3 years, these things will be much more available.
I thought you were going to say longer, actually. And that sort of brings me on to my next question. So in 30 years' time, 20, 30 years' time, the equivalent of you, Naomi, what will she be doing? Will she be looking back, let's say 50 years' time, will she be looking back on the current Naomi Fineberg and say, and what we're all doing, trying to find new treatments, and say, well, it's a little bit barbaric the way they treated OCD, and the idea of CBT and SSRIs being the first port of call. Will they be looking back and saying we were a little bit backward?
Yeah, I think barbaric may be a little exaggeration.
I apologize.
Primitive or backward, I think, sounds more like it. I started psychiatry when we only had clomipramine and Afronil, which in 1980 was shown to be effective by my own tutor, Professor Stuart Montgomery, who I learnt from. And he and colleagues had found that clomipramine, we didn't have SSRIs in those days. So that shows you. So OCD was pretty untreatable then. So we've come a huge way. I shouldn't, underestimate the advances we've made in understanding OCD and in treating OCD.
Would you ever diagnose those things that you were taught to would you ever prescribe those things, those drugs that you mentioned?
Yes, we use very frequently.
Nowadays?
Yes, we use it nowadays, but it has more side effects than SSRI. So I would use it third line. If the SSRIs don't work, it's an older tricyclic, and it causes, constipation, and it can make you a bit drowsy. So we wouldn't use it first line. We'd use it second line. It's very effective. But moving on, and we now know a lot in the about the neuroscience of OCD. There have been huge advances. I've alluded to the clinical advances seem to have lagged behind a bit. My guess is that the treatments aren't going to change hugely over the next 30 years. The modes of delivery might change. So we may have digital forms of these treatments so that they penetrate much better. I was saying that you can get it online, but we're not really very good at that. So we might be able to deliver your treatment online in real time in your home. You might be able to use digital monitors, a little bit like Fitbits, to identify how you're doing and take control of your treatment much more yourself. But I think the area where we're going to get much better at is in personalizing the treatment. And this takes me right back to the beginning of our conversation and me saying, I don't know who can stop treatment and who can't. I don't know which of you, if I had 3 people in front of me, I'd just say to you, and they said, which should we have? I'd probably say you pick and choose, because I don't know at the moment, based on your presentation, whether you should have CBT or medication or transcranial stimulation. I think this is where we're going to get much smarter. If you think about cancer, when I started, if you had a lump in the breast, it got removed, and then you all had the same kind of chemotherapy and radiotherapy. Everybody had the same. Nowadays, if you go to a cancer specialist, they do many more things. They will genotype you and look to see if you have any particular genes. They'll look at the hormone profile to see if your tumor is hormone responsive or not. And then they'll give you a personalized treatment for your own brand of tumor. The same, I guess, is going to apply to OCD, because we're starting to learn that OCD is a mixed bag of things, and different kinds of OCD are going to respond differently to different treatments. I think that's going to involve us looking, we talked about it running in families. There's a strong genetic element to OCD. We know, for example, that if you have a family history of OCD, you're less likely to respond to CBT on its own. You might be better off having the combination or medication. Now, why is that? That must be something to do with the gene. It must be something to do with a protein in your brain and how your brain is organized. So I think we're going to move towards much more personalized care, where we're going to be taking gene samples. We're going to look at your DNA and look at your genetic basis. We're going to marry that with your family history. We're going to look at your life events. We're going to look at your hormone levels. There's a whole other group of OCD that happens after delivery, in women after they've had a baby. So we're going to look at whether it's a hormone dependent form of treatment. We're going to look at your immune status, because a whole other group of people who seem to have a lot of antibodies, and there may be an immunological reaction to the brain in some people that causes OCD. So for them, immunological therapies, things that act on the immune system, might be helpful. And so we're going to really do a very detailed assessment to come up with an algorithm, a bit like when you go to the GP and he decides whether you go on a statin or not, an algorithm to say, well, you've got this, you've got this, you've got this, you've got this. Yes, we know you've got OCD, but you've got these other things as well. That means this treatment will suit you and this treatment will suit you. And that personalized care is something that I think will then make the success rate so much better. So we won't be saying 30%, are failing. It's because we're just giving you the blunderbuss treatment. We're much more refined in the way we target the treatments. And that is coming. I know that National Health Service research organizations are very interested in funding that kind of research, because it makes great cost-effective sense as well. It means that the treatments will be used much more efficiently. We won't be wasting them on somebody who is quite obviously wouldn't respond because they've got the wrong makeup. So I think that's where we're going to be headed.
I mean, that sounds like a really positive message. I mean, just for me listening to you for 55 minutes, I feel really positive about that. That sounds really good. And you talking about new treatments maybe coming in the next 2 or 3 years. That's a really positive message. And I don't suffer from OCD. If I was struggling with OCD and the current treatments weren't working, I know it's a few years, but that feels good. It feels like we're going in the right direction.
No, it is positive. There are other psychological forms of treatment as well, if we've got a moment. As we understand the brain circuitry and the psychological mechanisms underpinning OCD, there are refinements being made to the exposure and response prevention that might in the end turn out helpful as well. So a lot of OCD we know is habit. People tell us after a while it's just become habit. And there are treatments that we use, for example, for hair pulling disorders and skin picking disorders that involve actually using the same muscle groups and doing something else, using like a squeeze ball or something. And so the benefit of OCD having moved into this other group of disorders where hair pulling disorder is there, skin picking disorder is there, hoarding disorder is there. It allows us to look laterally at these other psychological treatments that have been used for these other disorders, see if we can apply them to OCD as well. So I know there's a lot of research going on looking at challenging habits to really amplify and strengthen the exposure response prevention, to break the link between the urge to do something and the actual doing it, by maybe, looking at other sort of benign habits and practicing those instead, might make the ERP easier to do. So again, watch this space. It's not all in biological treatments. There's a lot of psychological developments as well going on.
Naomi, I could talk to you for hours. I think I probably will. I might call you up after this because it's just fascinating talking to you and getting your expertise. And I know the people who have been watching, and this will be online as well, so there'll be many people watching after this, will have learned a huge amount. Thank you everyone, very much for the people who have sent in messages. They have really sort of helped be the spine of this conversation, and it's really good hearing. I think from the OCD community and people who know people who have OCD from around the world, I think it really gives us a great insight into what people are thinking in America, and we had someone from Canada, but also here in the UK. So that's great. I really appreciate everybody, your questions that have come in. But main thing is, Naomi, it's been a real pleasure talking to you, and I'm really grateful that you spent an hour with us, because I know you're a very busy person. Are you back to clinic now?
I am back to clinic now, but my final message to you all, because I know how resilient you all are, is hang on in there.
That's a really good message. Hang on in there. And that comes from one of the leading experts in OCD research. So you better listen. So Naomi, thank you very much. And thank you everyone for watching. And we're over our time. It's after 5 o'clock here in the UK. So I'll have to end the broadcast now. Thank you very much.